Good evening, ladies and gentlemen. I am Indrani Malkani, Managing Trustee and Chairman of the Citizens Action Network. A warm welcome to all of you to our social Sanchar. On the eve of World Stroke Day, on 28th of October, we had a session with Dr. Anil Karapurkar, interventional neurosurgeon and senior consultant of Bridge Candy Hospital. And the overwhelming feedback that we received prompted us to have the second session with him. I must at this point also mention that stroke, which is quite the leading cause of premature death in many countries, even in India, and in fact, 1 million deaths per year happen in India. Most often, the whole care is left to the family, and it is quite challenging for the family in every way, because if the correct diagnosis and the correct treatment doesn't happen where a stroke is concerned, the person is disabled and is totally dependent on their family. So last session, Dr. Karapurkar had dealt with in a more general aspect and on ischemic strokes. This session is particularly geared towards hemorrhagic strokes, more when the doctor takes his session. Before we start, may I share a little bit about us in v2.0. v2.0 is a registered public trust. It is a non-political, non-profit organization, and our primary objective is to establish linkages between the government and the citizens. And we work in partnership with various government authorities. Our focus areas include aspects of health, waste management, air pollution, road safety, cybersecurity, electoral processes, among others. Many of you have been following our work and have been visiting our web portal, www.TogetherVCAN.in, which is a platform where multiple issues are dealt on a single platform. And many of you are also regulars on our live interactive talk shows, TogetherVCAN's Social Sanchars. Your encouragement and participation have been our prime motivation to move ahead with our work. With the ongoing COVID situation, even though perhaps we may think that we are a little bit better off than we were a few months ago, but still there is a lot of challenge ahead of us. So with that in mind, we had started our new version of Social Sanchar, which are fully digital, and we started and expanded actually our Social Sanchar with a new series on health and well-being, featuring leading doctors and healthcare professionals as our speakers. We hope this new series, which we will continue, as will our normal Social Sanchars too, will receive as much support from all of you. I must thank particularly our support partner for this evening's Social Sanchar, Mr. Sanjeev Gandhi and Hester Diagnostics Private Limited. Without their help, it would have been difficult to bring this session to all of you. I thank Team Technolegion for powering this version of our digital Social Sanchar, as well as keeping constant vigil on our web portal and keep it going. I also thank Mr. Sumit Lula, our consultant for social media. And most delightfully, I would especially like to thank the Student Council and the students of our college partner, Jai Hind College, and all the clubs that are associated with Jai Hind College. And also the support of all the students from other colleges who have associated with us through our college partner, Jai Hind College. I thank our friends in the media and all of you for joining us today. May I now request my fellow trustee, Mr. V. Ranganathan, our former municipal commissioner, and who also led the state of Maharashtra as the chief secretary, to introduce our guest speaker, Dr. Anil Karapurkar, this evening. Mr. Ranganathan, would you please introduce our speaker for this evening?
Good evening. A great pleasure in welcoming Dr. Anil Karapurkar to the second part of the digital social Sanchar on the subject brain stroke. And this is a program in which we are fortunate to have a person of the expertise of Dr. Anil Karapurkar. After MBBS, he did a double master's in surgery and neurosurgery. Then he had specialized training in France on what is called neurovascular intervention. And presently, he is not only a senior consultant in British Candy Hospital, he is also a teacher in a new branch of medicine, neurovascular intervention. He is the president of the Indian Society of Neurovascular Intervention, has been president of the Asian Federation, and is also a member of the World Governing Body of Neurovascular Intervention. We are indeed fortunate to have him with us, and with the enormous public response we had to his last program, we do look forward to an enlightening program so that the common man can understand something. And people are worried about two issues. One is, how do they prevent these type of stroke? What measures they can take to minimize the possibility? And second thing is, in the present scenario of COVID-19 pandemic, does it accentuate these strokes? What can be done in this regard? So with these words, I welcome Dr. Anil Karapurkar, and we look forward to a very educative and informative presentation. Thank you.
Thank you, Mr. Ranganathan. Mr. Karapurkar, adding to what Mr. Ranganathan has already stated, I understand that today's session we look to understanding hypertension and aneurysms in particular, because there is a great lack of awareness about strokes amongst all of us. So also, how much are these hemorrhagic strokes different from other types of strokes? And what are the leading causes? What are the risks? And is emergency treatment required for cerebral, hemorrhage? Many of these issues have been highlighted to us in the last few days whilst we send out the invitation. So look forward to your presentation, Doctor, and do take up all these issues. Thank you. Dr. Karapurkar, please.
Thank you, Indrani, and thank you, Mr. Ramanatha. And I must thank Sanjeev Gandhi, my close friend, Nestor Diagnostics, and of course, Jahin College for supporting this endeavor. As I said last time, we covered ischemic stroke. This time we talk about hemorrhagic stroke. There is, as Indrani said, an absolute lack of awareness about stroke. So, last time we had tried to clarify, give some information about ischemic stroke. Today we'll talk about the hemorrhagic stroke. So, what is stroke? Sudden loss of function of a part of the brain, which may lead to paralysis, it may lead to loss of vision, it may lead to imbalance, and it is the second most common cause of death in India. So last time we had said 85% of strokes are ischemic, and until 2015 we were nihilistic about ischemic stroke, but today we are very gung-ho because we can do something. We have spent a lot of effort in the last 20-25 years on hemorrhagic stroke. Companies have given us better and better devices for hemorrhagic stroke, which constitute about 15% of all strokes. And as Indrani said a little while ago, there are millions of patients of stroke in our country. India being the capital of diabetes, diabetes is one of the uh, what shall I say triggers for stroke. So we are also the stroke capital of the world. I had talked about shown these images of the brain, and I'll just remind you: the right side of the cerebrum controls the left side of the body. The left side of the cerebrum controls the right side of the body, and in a right-handed person, speech area is on the left side. The cerebellum, the small brain, is uh, the small brain at the back. You can see the arrow now. So this is the cerebellum. Right cerebellum controls the right side of the body. There's imbalance, the hand sways, there is no control over it. The brain stem, which connects the two, controls both sides. So if there is something in the brain stem, both sides of the body will get affected. And the representation in the brain is upside down. The face is down, the leg area is at the top. And the visual cortex, the brain with which we see, is the violet area here at the back. So this is called the occipital cortex. And the blood supply of the brain, as I said last time, is a complicated circle, which is called the circle of Willis. We have so shown a complete arm here, but many times one of the arms is missing. But nature, as far as possible, tries to provide some form of what we call collateral. So from it will go from left to right, from behind forwards, and so on. So this is essentially the supply of the blood to the brain. Today we are talking about hemorrhagic stroke. So what are the causes of hemorrhagic stroke? The hemorrhage may be inside the brain. We then call it intracerebral or parenchymal. It may be subarachnoid, which is on the brain. It may be intraventricular, which is in the cavities of the brain. The most common cause is high blood pressure. This is the most common cause of brain hemorrhage. Almost 65 to 70% patients of hemorrhage, intracerebral hemorrhage, the cause is high blood pressure. Aneurysms are like blisters on an artery. You can see this here. This, the red arrow, this blister, this is like a blister on an artery. This is the size of a tennis ball. It's a huge aneurysm. And this is a very delicate structure which can rupture anytime. AVM, arteriovenous malformation, is a bunch of blood vessels. We see another red arrow here. I don't know whether you can see my arrow, but if you can, I've written also here. AVM, that's a bunch of blood vessels. That's like a honeycomb. One of these honeycombs can rupture, leading to brain hemorrhage. And this is the hematoma or hemorrhage, which is the result of high blood pressure. Intracranial venous thrombosis is something that we see a lot of in India. It's not so common in the rest of the world, but this is also a common cause of brain hemorrhage. Why does hemorrhage occur when the pressure, because of hypertension? Most common cause is when there is a sudden surge of blood pressure. If you have high blood pressure of long standing, that doesn't matter. But in addition to high blood pressure, if there is a sudden jump in your blood pressure, that is when hemorrhage occurs. So, supposing one is very angry, one is very emotionally disturbed, then hemorrhage can occur. Many patients think they get fed up of taking high blood pressure medicine because they need to take them lifelong, they stop. Stopping medicines, blood pressure medicine is very dangerous because that is when the blood pressure suddenly shoots up and results in hemorrhage. And many people don't bother. They've never had their blood pressure checked in their life. They may be 70 years old, 80 years old, they've never, हमको कुछ नहीं, हम बिल्कुल ठीक हैं, हम क्यों कराएं? But such patients many times present to the hospital, to the emergency, with a huge hemorrhage into the brain, and their blood pressure is sky high, and they've never had it checked. So this is the first evidence that they have hypertension. But if the ECG is taken, one will see the changes of chronic hypertension, long-standing hypertension, where the ECG will show changes in the heart. So the most common cause is either stopping of blood pressure or an emotional upset leading to a hemorrhage. Generally, there is severe headache when a hematoma occurs, but not necessarily. Many times you have patients who do not complain of headache. If there is headache, often there is nausea and vomiting. Paralysis is more common. Sudden onset paralysis of one side without headaches. And if it is a small hematoma, there will only be a small focal deficit. So it may be only one face, only one arm, only one leg. If it is a big hematoma, there's a complete paralysis. Many times the patients are unconscious and they get convulsions. So if a patient is unconscious from the beginning, or if the patient gets fits from the beginning, then it is not a nice thing. It means that there is a big clot. So the first thing is, if anything like this happens, always don't call your GP. I always say, go immediately to a multi-specialty hospital. If the patient is getting convulsions, make sure that he does not hurt himself. So turn him over to the side so that whatever vomitus is there or any saliva which is there, it will all drool out and he will not swallow it or it will not go into his lungs. So most important is to make sure that he does not injure himself further. And like it is for ischemic stroke, for hemorrhagic stroke also, we need to have some form of imaging. Without CT or MRI, there is no way of knowing what has happened. So we have to do a CT, and if we add a CT angio to it, then we know what is the cause of that hemorrhage. Many times, in a hypertensive clot, you cannot determine the CTA will not show anything. But if it is an aneurysm or an AVM, then it will be seen on the CT. Similarly with MRI, I'll just show you some examples. So the upper row is all CT scan, and lower row is MRI of the same patients. So on a CT scan, fresh hematoma is white. As you can see here, it is white. So this is deep in the brain. This is in the brain stem. Now, something in the brain stem is inaccessible to us surgically. We cannot get to this. To get to this hematoma, which is tiny, we'll have to destroy a lot of brain, to cut into a lot of brain to reach there. This again is a large, deep hematoma, but this has burst into, we call these ventricles, this black shadow and the white shadow. So these are cavities which are called ventricles. So sometimes when a clot like this bursts into the ventricle, it saves the life of the patient. So you can see this is white on the CT scan and various shades of black on MRI. This one, the last one here, is a cerebellar hematoma. A cerebellar hematoma is an emergency. It needs urgent treatment because many times surgical cerebellar hematoma patients deteriorate very rapidly. So the clots may be of different sizes. So this is a large, deep clot. This is a large, deep clot again, which has burst into the ventricle. This is a large surface clot which has burst into the ventricle. So these almost certainly are because of high blood pressure. This is probably because of an AVM, an arteriovenous malformation, which has ruptured because it is coming onto the surface. The cerebellar hematoma, you can see the size of this one. This is huge. This is lethal. This will kill the patient unless something is done rapidly. Brainstem hematomas, like I told you, these are inaccessible. These are the brainstem hematomas. If you can see my arrow, these are inaccessible and we can't do much for them except to treat them conservatively. So what is the treatment? We treat conservatively or we give surgical option to some patients. So if it's a small clot, we treat it medically only. So what is the medical treatment? We have to reduce the intracranial pressure and we have to control blood pressure. Why does intracranial pressure rise? Because the skull is a closed cavity and the contents, the brain, weighs about 1500 grams. But if clot is added, say a 100-gram clot is added, there is no space for it. So the pressure inside the brain rises. And sometimes the pressure inside the brain may be more than the blood pressure, in which case the patient dies. So we have to control the intracranial pressure and also the blood pressure to prevent a rebleed again, a hemorrhage again. So these are the two goals of treatment, medical treatment. Reduce intracranial pressure with medicines and control blood pressure. And if it is a big clot, more than 40 cc, with compression of the brain, or if there is a clot within the ventricles or a cerebellar hematoma, like I told you. These are surgical candidates. So this is what happens to a clot. See, this is a small clot which you can see here. After 7 days, it has become smaller. This was densely white. This is on day 1. On day 7, it has become less white, almost gone. So if you don't do a scan soon after this has happened, you may miss a scan. You may miss a clot because after 2 weeks, you can see the clot is gone. It is replaced by a cavity which contains fluid. So the appearance of the clot changes and the clot disappears on its own. So a small clot does not need surgical treatment. It is only medical treatment. If it is a big clot, on the other hand, like this one, which is causing pressure on the brain, nowadays the surgeons have beautiful technology. We have the operating microscope. We have something called the endoscope. So we make a small hole in the skull, and through this small hole in the skull, without damaging the rest of the brain, we can get to these deep areas and we can suck this clot out. So you can see this is pre-surgery. There is a big clot here, and this is post-surgery. So we have to do this as early as possible. So as soon as the blood pressure is under control, most of the times, as soon as the blood pressure is under control, the operation is done. And if we want to salvage the patient, salvage the strength of the patient, then we have to do it early. So here, not only do we save life, we also save function. There is paralysis, the paralysis recovers. This again is a small, deep, relatively small, deep hematoma. But if you see, the whole brain is getting shifted. The right side of the brain is getting shifted to the left side. So this is because of pressure. And if you see the post-operative scan, through a small hole in the skull, the clot has been removed, and all this pressure has been relieved. So the aim of surgery is to remove as much of the clot as one can and to relieve the pressure. Now this is a blood. This is in the lower slide, in the lower part of the slide. Blood in the ventricles, in the cavities. This also will gradually disappear on its own, but this causes rise in pressure. So many times we place a tube, we call it a drain. We place the tube through a small hole, and this operation slide shows how that small drain is being inserted. So make a small hole here, we call it a drill hole. So this is like the electricians or the carpenter's drill. We drill, it's the same thing, or we have an electrical drill with which we drill the hole, and then we insert this drain which goes from the skull into the cavity, and the blood is drained. So this is called an EVD, or external ventricular drain. External ventricular drain. If it is a cerebellar hematoma, we have to operate early because this can be lethal. The space here is very small, and usually with a cerebellar hematoma, water collects. So here you can see this patient has got this drain to drain the water to reduce the intracranial pressure, and also an operation has been done and the clot has been evacuated. In fact, in cerebellar hematomas, the blood pressure is usually very high and very difficult to control. And we need very high-powered injections to bring the blood pressure down. And we operate and remove the clot as early as possible in the posterior fossa. This is called the posterior fossa. Cerebellum area is called posterior fossa. Sometimes, for a deep hematoma, it may not be possible to actually remove the clot. In that case, this is the closed skull. We just make a hole in the skull so that the brain can bulge outwards and relieve the pressure. So in this patient, you can see the severe shifts across we call it shift across the midline. So from the right side, the whole brain is shifted across to the left side. And post-operatively, that shift has become less prominent, as you can see here, and the brain is bulging outwards. So this is to relieve pressure. And this last set of images shows what happens in the long term in such a patient. So this is a patient who has a large hematoma. You can see the pressure on the brain. So a huge, we call it craniectomy. The overlying skull is removed. We keep that skull aside, we open the covering of the brain that is called the dura. That's a really tough covering which needs to be cut. So we cut that, let the brain bulge outwards. So that is on in the second row. And in the third row, you can see that the clot is gone. The pressure on the brain is gone. It is almost normal now. So usually after 3 weeks, we put that bone flap back. We call it a bone flap. We have raised the bone flap. We save it. We either refrigerate it. Nowadays we get very good artificial bone also. So made to measure for the patient. So we put them back after 3 weeks. So what was a big cavity, a big hematoma, results in a small cavity, say after 2 months or 3 months. So for a hematoma which is small, the prognosis is excellent. They will do very well. Even if there is paralysis, they will recover. In a hematoma, there is no destruction of tissue. In an ischemic stroke, brain tissue is destroyed. So recovery is never so good. In a hematoma, the recovery is good. So if the hematoma is small, if the hematoma is superficial close to the surface, if the patient is conscious and has only a focal deficit, patient will do well. If it is a large hematoma or a deep one or intraventricular hemorrhage or the patient comes deeply unconscious, then the prognosis is not so good. They don't do so well. So basically for high blood pressure, the first thing is to be aware. So anyone over the age of 40 or 45 should have his blood pressure checked periodically. If the pressure is high, it must be treated, not only for the heart, but also to prevent hemorrhage. So blood pressure treatment once started has to be continued regularly. In young patients also sometimes blood pressure may rise. So we do see patients who are in their 20s, in their 30s who have very high blood pressure. Sometimes they present with a hemorrhage and then we find, your blood pressure is so high. And often in young patients, one has to investigate to find why the blood pressure is high. And most commonly, the cause is the kidney. There is some disease in the kidney. There is some narrowing of the kidney arteries. So if there is some narrowing of the kidney arteries or if there is some kidney disease, that needs to be treated before blood pressure can be controlled. So in young patients, think of some other cause for blood pressure. And blood pressure medicine, I will reiterate, should not be stopped. Or if it is to be stopped, it should be only on the advice of the doctor. Do not stop treatment on your own. Even missing one tablet can be lethal. If there is a big hematoma, patients die before you can do anything. So please, if you have your blood pressure checked periodically, make sure that you take your medicines. If you are traveling, this happened to me also. We had gone abroad and we found that we had to extend our stay and we did not have enough tablets. And getting buying tablets abroad is not easy unless you have medical prescription. A prescription from India is not enough. You have to get a local prescription. So if you are traveling, you make sure that you have a proper extra medicines so that you don't run short, especially blood pressure medicines. And second thing which we always say you should carry is medicines for convulsions, for fits. So I mentioned earlier that one of the symptoms is fits. So if a patient has had a fit, he should be on medicines to prevent fits. And if you are traveling, you make sure that you have enough medicines to cover any contingency of extended stay. Of course, in the COVID time, people's stays have been extended by 6 months and 8 months and 9 months. Those are unforeseen circumstances. But at least for 2 weeks to 3 weeks, we should have enough medicines to cover everything. So this is about hypertensive bleed, which is the most common cause. The next common cause is what we call subarachnoid hemorrhage. Subarachnoid hemorrhage most commonly is because of some rupture of an aneurysm. Aneurysm is a blister of an artery. It can also be seen after head injury. It can be seen after that bunch of blood vessels, AVM rupturing, and in some patients who are on blood thinner medications. So this is what subarachnoid hemorrhage looks like. This is a specimen of the brain of a patient who has died. An autopsy was performed, and this it's all on the surface of the brain. So when an aneurysm ruptures, a blister ruptures, the patient gets sudden severe headache. This headache is something which is very, very severe. It is almost always accompanied by vomiting. Usually there is neck stiffness and pain. Sometimes there are convulsions, and sometimes the patient may be comatose. So even if a patient has migraine, has, we call it, habit of getting headache, if the character of the headache is different, if it is very severe, if it changes its nature, don't assume that it is the same. Get some form of imaging, and CT scan is the simplest. And aneurysm, when it ruptures, is very dangerous. If the hole is big, 100, 150 ml of gone in a matter of seconds, and the patients are dead within the blinking of an eye. One third are in such poor condition that we cannot treat them. Their heart is not stable, they don't breathe properly. Only in one third patients do we get to treat them. And the best investigation is either a CT and a CTA, an MRI or an MRA, or a DSA. DSA is digital subtraction angiography. For an aneurysm or for an intracranial subarachnoid hemorrhage, DSA, digital subtraction angiography, is the gold standard. One must get a DSA done. I'll just show you what I mean by that. So this is a CT scan. You can see the blood is not inside the brain.
What happened? Doctor has moved away from the screen. For some reason, doctor has, I think the connection has gone. He will be back.
Yeah.
Doctor will be back. But whilst we are waiting, from what we have just been hearing, I think there is such a lack of understanding about stroke that it is scary. Because whilst we can deal with all other organs, the brain is actually what we are. So if anything happens to the brain, then we as a person lose our identity. We are really gone. So that is why I think knowing about strokes and understanding what we need to do from the family point of view, from, as a bystander, so much work is there in this field that we wonder that how much is required in this field. Strangely enough, we talk about heart attacks, we talk about diabetes, and we just heard from doctor that diabetes is one of the most dangerous things where strokes are concerned. It's one of the strong triggers. So in all the diabetic patients, there is a need for people to understand that what is at stake. Not to sound alarmist, but certainly we need enough. Thank you, doctor, for coming back. I was just wondering what happened. But then you see, the digital world has its own challenges. So never mind, it happens. So shall we take on from where we were? Would you like to show us?
Luckily, we are back at action.
Yes, we are. So let us understand this very colorful video that I can see, your angiogram, 3D, yes.
How far had we come?
Actually, we were discussing about the, the different imaging. But perhaps you might want to show us this film.
Yeah. So
with the video.
So this is called a. This is a CT scan showing the subarachnoid hemorrhage.
Yes.
Yeah. So this is called a 3D rotation angiogram. So for a small aneurysm like this, you see that small little blister? It's like a mushroom. It's a tiny one. But this can cause death. A huge amount of blood can escape in a matter of seconds. And this is what we call a 3D rotation angiography, where we can spin it around. We can spin it around. We can stop it. We can look at it from inside and outside. We can do virtual endoscopy. So subarachnoid hemorrhage is dangerous. So when we are dealing with an aneurysm, we are dealing with two parts to it. One is the treatment of the aneurysm itself. The second is the subarachnoid hemorrhage, because there are a lot of sequelae to the subarachnoid hemorrhage. So one is it can bleed again. Like I told you, when it ruptures, 1/3 die. If it bleeds again, and rebleed is very common in the first 24 hours, the chance is a 3 to 4% chance of rebleed. But in the first 3 weeks, about 1% per day. So 21% of patients rebleed in the first 3 weeks. So that is one problem. And when it rebleeds, 50% die before you can do anything. Another thing that we don't understand about and why it happens is spasm. This is something very peculiar to aneurysm. By spasm, we mean arteries become narrow. So I'll show you an example. Arteries become narrow and blood does not go to the brain. Usually the spasm is on the side of the bleeding, but it can be on any side. Hydrocephalus is where there is a collection of water. And salt imbalance is again very common. Sodium, potassium, magnesium, the common salts play havoc, and we have to keep correcting them. So any patient with subarachnoid hemorrhage stays in the ICU for at least 2 weeks. In ICU for at least 2 weeks. How do we treat them? Strict bed rest. We monitor blood pressure, ECG, glucose, and electrolytes. Electrolytes is sodium, potassium, magnesium, the salts. And we treat the aneurysm as early as possible, so that if there is any complication of the subarachnoid hemorrhage, we can treat it. So how do we treat them? There are two ways to treat aneurysm. One is to open the head. We open the head and put coils, put clips inside. The other is what we call minimally invasive, which is endovascular. We go through the groin, and place platinum coils or different devices inside the aneurysm. So this is some set of pictures of the operation. So this is I told you, we raise a bone flap. So this is a scalp flap. We make a cut in the brain, in the scalp with the skin. We raise a skin flap. Then we cut a bone flap. Then we can see the brain which is exposed. So we actually don't open the brain here. We go in the space between the brain, in the subarachnoid space, and we try and put a clip around the neck of the aneurysm. These clips are also very special kind of clips, high precision engineering clips. Most clips, any clip, you squeeze to close the clip. Aneurysm clips, we squeeze to open. In fact, they close when we release it, and they open when we squeeze it. So the whole principle of an aneurysm clip is different. So these are very precise, high engineering, very specific type of clips. And the clips today are all MRI compatible, so that you can do an MRI later. So these are made of special material called titanium clips. And so you can see that aneurysm here, which has been nicely exposed. We call it dissected. So the aneurysm is dissected, and here you can see the clip. So once the clip is on, the aneurysm, which was like a big blister, has become tiny and innocuous. So this is how surgery is done. Not all aneurysms are accessible to surgery, but some location aneurysms are easy for surgery. But today we don't need to open the head. We can treat these aneurysms without opening the head, and therefore much less invasive and much safer. So for that we have this cath lab. I mentioned yesterday that we had a biplane I had shown you last time. So this is a monoplane cath lab. But like I said last time, this is a neuro lab. This is not a cath lab. And the difference is that on the neuro lab, on this table itself, you can do a CT scan. You can do a CT scan and you can see what has happened. So briefly, this is how we do the thing. We make a puncture in the groin. We take a catheter up from the groin into the what we call arch of aorta. From there, we go into the brain artery, the carotid artery or the vertebral artery. From there, we take a tiny catheter which goes into the artery which has the aneurysm. Then we take a tiny catheter into the aneurysm, and then we deploy these coils. So these coils are made of platinum. So this is a video to show how it is done. So this blister you can see is lying here. So you can see this catheter is coming up. So this is all done under vision with a special technique called road mapping. So this first coil is deployed against the wall of the aneurysm. So we make a scaffold, and into that, so once the coil is inside, this is a very high precision engineering. So we try and use a coil which is of that diameter. Supposing this is a 5 mm aneurysm, we will start with a coil which is 5 mm in diameter, which would be around 10 or 15 centimeters long. Supposing we start deploying the coil and we find that we have goofed up, it is too small or too large, we can pull the coil back. That is the great thing about this. So we keep on pushing, and once we are satisfied that the coil is completely inside the aneurysm, it is nicely inside the aneurysm, it's going to stay inside the aneurysm, we can detach it. There is a special detachment device with every coil. Mr. Sanjeev Gandhi and Hester Diagnostics are one of the suppliers of this type of devices, the coils. So these are made of platinum. Some coils also have a coating on them. So the first coil is against the wall, and into that we pack in as many coils as we can. So this is an example of a patient. She had 3 aneurysms. She had one in the middle and 2 on either side. So the question when there are 3 aneurysms is which is the one which is ruptured. Always a problem. Very difficult for us to decide. Luckily for us, when we see a beak like that, we see a beak in this aneurysm. This is the source of the bleeding, and this is the one we have to tackle. So we always treat the source of the bleeding first. But in this patient, we have treated all 3 together. All 3 coils. You can see these are the coils inside. So this is a DSA. I told you this is the digital subtraction angiography, where we see only the artery. We don't see anything else. This is non-subtracted angiography, where we see the skull at the back. The cardiologists work like this, with the skull at the back, with the chest at the back. We work subtracted like this, where we see only the artery. See, these 3 images are only the artery. We don't see the skull at the back. So this patient was treated, I think, in 1999, almost 21 years ago. And we did a 5-year follow-up, and these are the 3 coils you can see very beautifully. And she stays stable. She is very well. In fact, she was the wife of one of our union ministers. So coiling is easy if the neck of the aneurysm is narrow. If the neck is broad, see like this one, but if we put the coils inside, the coil will fall back into the parent artery. So the coil will prolapse into the parent artery and block the parent artery. So what we do is we use a balloon. So here we have a balloon which we position across the neck of the aneurysm. We inflate the balloon, and then we deploy the coil. And once the coil is fully deployed and we are happy with the position of the coil, then we deflate the balloon and we make sure that the coil stays in the same position that it was. And then we detach the coil. So that is the detacher. That's one other company. So the first coil is deployed against the wall. This is another balloon which is a very hyper, we call it a hyper form, because it bulges into an adjacent artery. So for small arteries, this is the balloon that we use. And again, we do the same thing. So these are the balloons that we use to deploy coils. So this is a patient, again, I've treated more than 20 years ago. She was the wife of an ENT surgeon. And she has this large, wide neck aneurysm here. And here we have used a balloon. So this is the balloon sitting across. This is the catheter inside the aneurysm. So we have deployed these coils. We deflate here. We deflate the balloon. This balloon inflated. Here the balloon is deflated. We make sure that the coil stays inside. We pack the aneurysm as tightly as possible. And this again is a lady I treated 20 years ago, and she's doing very well. I keep seeing her every year. So sometimes it is so broad that even a balloon is not enough. Then we have to use a stent. And these are special stents meant for aneurysms. So these stents are very delicate, they are crimped inside a microcatheter. The microcatheter is a very delicate thing which can go traverse all those bends in the arteries. The only disadvantage is that these patients have to be on blood thinners for life. So this is a video of so here you can see the catheter coming in, and we will, so once the microcatheter is there, then we bring the stent out, and when we pull the catheter back, the stent gets opened like that, see? And once the stent has been deployed, then we bring a microcatheter which will go, sorry. So the microcatheter goes through the stent, and then we coil the aneurysm. So this is called stent assisted coil. So this is when the neck is wider. This also has been available since 2002. In fact, the very first cases in the world were done by us. One in Mumbai by my colleague Uday Lima in KM, and one by me in Apollo in Delhi. So these stents are very delicate, and we cannot see the body of the stent. We only see the front end and the back end. And these are the coils. So this is a patient that again I have treated many years ago, and patients are doing extremely well. Today what we are using more and more is something called a flow diverter. This is also a kind of a stent, and this is essentially used for patients where we earlier did not have any treatment to offer. Giant aneurysms. Aneurysms which are 4 centimeters in diameter, 5 centimeters, bigger than tennis balls. Those we had no answer for earlier. But today we use this flow diverter. So this is how a flow diverter is used. So the principle is the same. The only difference is the construction of this flow diverter is different. So it is inside a sheath. When we pull the sheath back, the stent opens out on its own. So you can see that the stent is being deployed there. And once we deploy the stent, the flow diverter, the aneurysm slowly closes down, and by 2 years, by 2 months, the aneurysm is gone. The only problem with the flow diverter as of now is the cost. The flow diverter costs about 8 to 10 lakh rupees. But look at this. This patient had this giant aneurysm. This is like a table tennis ball, bigger than a table tennis ball. And this is, you can imagine what it must be causing. In fact, it had caused paralysis of his eye movements. The patient had a squint. The patient could not see properly. The patient had double vision. And look at the artery later. Where is the aneurysm? This is the kind of reconstruction that we get. And this is all done without an operation. This is only through a puncture in the groin. In fact, many patients tell us, हमसे 10 लाख खर्चा करवा दिया, कुछ किया कि नहीं आपने? Because there is no stitch, there is no cut, there is nothing. Patient walks out of the cath lab walking virtually normal. So the problem with this is the cost, but safety-wise and outcome-wise, these are excellent. So today we have beautiful devices, and companies keep improving upon the devices, either the delivery device of the stent, or the engineering of the stent, or the quality of the stent, or the durability of the stent. So they keep on improving upon them. Hopefully the cost will come down, but as of now, the cost is quite high. And finally, I think in this part, I will talk about spasm, because this is something which has defeated us all these years, and we really don't know why it happens and who will get it. But 40% of patients with subarachnoid hemorrhage get this. So this is called spasm. See the artery here. This is on the day that I did the angiogram. There is some narrowing of the artery here. This is the aneurysm. But next day when we took her up for treatment, it had become like a thin string. The pipe had become like a string. So this is called spasm. Why it happens, we don't know. Usually it starts on day 4. Usually it progresses up to day 10, day 12, sometimes up to day 14. And then on its own it goes away. So we have to tide the patient over during this period when there is this narrowing. So we call that arterial spasm. And look at that artery here. So here it was narrow. Here it had become a string. And we have injected a medicine called nimodipine, which means the artery has opened up. So this artery, which was like a string, is like this. It's like a pipe. It is a pipe, but it has become narrow. So because it has become narrow, blood flow downstream becomes less. So these patients get an ischemic stroke. So they have a hemorrhagic stroke. They have subarachnoid hemorrhage. But because of this arterial spasm, they also get an ischemic stroke. So this we have to treat, and sometimes it can be very difficult to treat. We may have to take the patient back again to the cath lab and do this 2 times, 3 times, and things like that. So this is called.
Doctor, there is a question here. Immediately as you are speaking, are there any chances of probability of death in this process? It'll be a good idea if you answer.
Actually, today we have such good techniques and we have such good materials. That can, of course, occur. That can occur. The main thing is the aneurysm can rupture. Supposing the aneurysm ruptures during the time of anesthesia, this is done under full anesthesia. I didn't mention that. Aneurysms, all intracranial work, we do under full anesthesia. So this is like for a major operation. So the patient has an endotracheal tube. The patient is being monitored. The blood pressure is being monitored. The pulse is being monitored. Urine is being output is being monitored. So the aneurysm can rupture anytime. So it can rupture before we have started. It can rupture during anesthesia. We've had patients being brought from the ward to the cath lab, and in the intervening period on the trolley, they have ruptured. They have become unconscious. We've had patients being shifted from the trolley to the table, becoming unconscious. So an aneurysm can rupture anytime. That is the main thing that worries us. If the aneurysm does not rupture, I think chance of death is very unlikely. Of course, it can happen because this is a very major procedure. This is, I'm showing you, it's a minor procedure. But today, luckily, with the kind of materials that we have, this is the kind of outcome that we get 99 times out of 100. In only 1% of patients do we get complications. So one complication is hemorrhage. The second complication is the artery getting blocked. We call it thrombosis of the artery, thrombus formation, because we are putting coils inside, we have got catheter inside, we've got a whole lot of stuff inside. So sometimes with the slowing of blood, clots can form. So the patients are always what we call heparinized. They are on blood thinners so that clots don't form. And the third worry that we have always is parent artery occlusion. If you see this aneurysm is sitting in the fork of an artery where the artery divides. This is the typical location of an aneurysm, a fork of an artery. So the coil which is supposed to sit only inside the aneurysm may prolapse into the parent artery. So earlier we didn't have an answer for that. Today we deploy a stent. Supposing the coil has come down, we don't. 25 years ago, 20 years ago, we didn't have an answer for that. But today, what we do is to deploy a stent. So the stent will keep the artery open. These stents, mind you, are special stents meant for intracranial arteries. They are very delicate stents. They are a little more expensive than the heart stents, but they are very, very, very good stents. So that can, of course, happen at any time. But today, luckily, with the kind of technology that we have, and we are doing everything under vision. So the chance of death is very small.
Well, you have another question here. So before your presentation can get completed, because people are interacting.
I think we'll stop now. I've talked what I wanted to say, but I can take questions.
Yes. So here they're talking about pituitary adenoma epilepsy.
No. That is a different subject altogether. Apoplexy. Okay. They're probably talking about pituitary apoplexy. Pituitary apoplexy is when a pituitary tumor ruptures. That results in hemorrhage. So I had shown you in my list of causes of hemorrhage, others. So that is one of the others as a cause of hemorrhage. That is a very rare cause of hemorrhage. There you have to treat the pituitary tumor. But sometimes, on the other hand, a giant aneurysm, the pituitary tumor is housed in a cavity of the skull called sella. And sometimes a giant aneurysm can project into the sella. And I've had instances where the surgeon has, especially in the days before MRI, thought that this was a pituitary tumor when in fact it was a giant aneurysm. And they cut into it, and then there was a fountain of blood. It is like a fountain of blood. So, pituitary tumor masquerading, I mean, an aneurysm masquerading as a pituitary tumor is a rare thing, but it happens. So, pituitary apoplexy is a rare cause. What is more common in India is, which I am not covering in because of lack of time, is intracranial venous thrombosis, where the veins of the brain get blocked. And the cause of veins of the brain getting blocked, the most common cause is dehydration, not enough fluid intake, and starvation. And there are many, we every year during the period of pollution amongst the Jains, they do anshan, they don't drink water, anshan vrat. So they don't drink water for 8 days and they come dehydrated. And you'll be surprised. There are some who said, I don't mind, like I will die, but I will not take water. So they get dehydrated, their brain veins get dehydrated, they get convulsions, they get hemorrhage into the brain. So that is a very common cause of, especially amongst Muslims during the period of Ramadan, if Ramadan falls in summer, because during the hot day they have not taken any liquid at all, or Jains during the period of pollution. But in India, we see it all around the year. I don't know why. We don't know why we've tried to make studies, but we don't know why the rest of the world sees female patients with cortical vein thrombosis. We in India see young males. And luckily, if the diagnosis is made, usually the diagnosis is delayed. It's not made for days or weeks, because the symptoms are very, very different. They are not easy to understand. And CT scan also may not contribute unless one is very suspicious and has such minor changes in the CT scan or MRI scan in the beginning. By the time the patient comes with a hemorrhage, it is too late. Patients are very sick. So intracranial venous thrombosis is one cause of a hemorrhage, which is much more common. The second thing which is much more common is a brain AVM. A brain AVM rupturing is much more common in children. So I'm sure all of us will have heard of instances of children getting severe headache, dropping unconscious during examinations. So with the tension of examinations, the children, their AVM ruptures, they get a brain hemorrhage, and it's a big hematoma, they are dead. Or they are deeply unconscious, or they get convulsions. So brain AVM is a much more common cause of stroke in children, not in adults. Adults also, but much more in children.
Here you have another question.
Yeah. So there is no such thing as what worries are. One is the radiation injury, because we are treating on X-rays. The earlier cath labs, the older cath labs, used to in India, like I told you last time, we have very few neuro labs. In neuro labs, you can control the amount of exposure. So we neuro people are very particular. I'm sure even the radiologists are very particular about how much radiation the patient and the operator gets, because we are doing for every patient. But the patient comes once, but we and our technicians are there all the time. So we are getting. So we have to have what we call radiation protection. So that is the main inquiry: radiation injury. So the newer neuro labs reduce the amount of radiation, but do not reduce the resolution of the image. What we are seeing on the screen is still very sharp, but the amount of dose, radiation dose given to the patient is reduced. So the question is quite valid, because sometimes, for instance, in the 90s and early 2000s, we used to see patients who used to have a loss of a patch of hair like that, a circular patch where there is a loss of hair. Patients used to say, I'm losing hair in clumps. They would lose hair for about 3 weeks, and then after 3 weeks, the hair would start, or 6 weeks, and then hair would start coming back. So there is some amount of radiation injury, but I think with the newer labs, it is much less than it was in the older days. And we try and reduce the radiation to the patient and to us operator as far as possible.
Okay.
I have a question.
Sure.
If owing to loss of blood supply for a portion of the brain becomes non-functional,
Yes.
then can it subsequently be made functional?
Yeah. So in a hematoma, in an infarct, what I talked about last time, the brain tissue is destroyed. So that brain tissue does not regenerate. But the adjacent brain takes over the function of the tissue which is destroyed. So this is a unique function of the brain. It is called plasticity. Because this unique function of plasticity, the adjacent brain takes over the function which is missing. In a hematoma, the clot is just expanding and squeezing the brain. So once the clot is gone, the brain expands and comes back. So the function is much better in a hematoma. Functional recovery is much better in a hematoma. And again, like I told you last time, motor recovery is much better. Strength comes back much faster. But sensations, supposing there is a loss of sensation, you touch here, I can't make out. You give me a pin prick, I can't make out. That we have no answer for. That there is no treatment for. But motor recovery, again in the motor recovery, the proximal muscles, the shoulder, the elbow, because these are big joints, recover faster. Hand is such a complex, so many different movements that hand always takes time. Hand, the wrist. So these are where the patients have to spend a lot of effort. The hand, the wrist, the foot, the toes. These are where patients have to spend maximum effort. So recovery is good, provided there is no. So in such patients, the first thing is saving life. So when we do a big decompression, we remove a part of the skull and then we put it back again. We are saving life. Then we talk about recovery of function. So many times we first talk about saving life. Then we say, okay, we'll see about function later, if the patient recovers. But there is no way of guaranteeing whether the patient will recover fully or not. But it is a rule. I mean, one can almost say, rule of the thumb: younger the patient, better the recovery; older the patient, lesser the recovery.
Okay.
So, in a patient in the 80s may not show much recovery because his capacity to recover is that much limited. Of course, if the patient is very strong-willed, we've seen patients who you think, "Arey, iska kya hoga?" But they recover and come back walking, and you don't know, are you the same patient who was completely paralyzed and not able to talk and all that? So we have miraculous recoveries. So especially for subarachnoid hemorrhage and big intracerebral hemorrhages, the surgeon's part is a small part. The intensive care and the nursing care is equally important. So I used to be, when I was in KEM, we used to get a patient where we had a complication. Almost certainly the patient would die. Because, I mean, I'm being very frank, but this is what would happen, and happens today also. Because in KEM, one nurse used to look after 4 patients and 5 patients in the ICU. In the ICU, the ratio should be 1:1. And I realized the difference when I moved from KEM to a private hospital. We have 1:1 patients where you think this patient is not going to recover, is going to remain paralyzed for life. They recover fully or dramatically. So what is very important is not only what we are doing in the cath lab or what we are doing in the theatre, the nursing care and the post-operative care, especially for subarachnoid hemorrhage, which is a very complicated problem. I've just mentioned a small part of the post-operative. So all patients with subarachnoid, if we do an elective aneurysm, supposing the patient has come, the aneurysm has been discovered, like that patient I showed you where the artery is completely normal, that patient, it was discovered because she had that visual problem. So she was admitted on the day of the procedure. She went to the ICU for a day. She was in the room for a day thereafter. And third day she was home. So that is the kind of outcome that we get in patients when they have not ruptured. But when they rupture, it's bad. Minimum
Doctor,
2 weeks in the ICU.
Right. Doctor, actually, there were quite a few questions from live came in. The last one was about what are the stroke symptoms of a 90-year-old? Has age got anything to do with the symptoms?
Symptoms will depend on which part of the brain is affected.
Right.
So, in subarachnoid hemorrhage, headache. Headache so dramatic in these patients. If anyone has had it, he will tell you, it's like bursting, it's out of the blue. Sometimes patients are in the bathroom, like I told you last time also. Many of our patients have had hemorrhage in the bathroom. It's very common. They've strained at when passing stools, or maybe the hot water on a cold day, in a cold winter day. Somehow, a lot of our patients get their hemorrhage in the bathroom. So, in the bathroom, as I said last time, doors should open outwards. Don't let
Always.
doors open inwards, because then it gets difficult to get the patient out. So, symptoms
Right.
will be the same depending on which part of the brain and
Okay.
how severe the stroke is. If it is a minor stroke, it's like a TIA, transient ischemic attack.
There was a question whilst you were speaking. If that question can be brought back from YouTube, one of our viewers had put up. Let's see if it comes up. There were questions which had come on WhatsApp, on SMS also, and it had to do with the cost. Was it? Actually, the students of Jai Hind College had quite a few questions themselves. So therefore, they put it they compiled the questions and send it to us, that perhaps one of them may have seen or otherwise. So could we have that question on WhatsApp which had come, if it can be displayed? Actually, there were about 7 parts to it, and some I think you have already answered. There are the risk factors, and how do you reduce? Of course, the symptoms you have already spoken.
So these factors are already discussed, but again, to
I think
refresh.
all of these. But I think
Diabetes, hypertension, hyperlipidemia, smoking, all of these are risk factors.
right. So when you go to the 7th question, that talks about strokes in teens.
Yeah.
So it will be the same things. And
No, in teens
no?
it is slightly
Is there
different.
a difference? Yes.
So one is the hemorrhagic stroke, like I told you. The hemorrhagic stroke is common in teens from AVM. When an AVM ruptures, arteriovenous malformation, rupturing, resulting in brain hemorrhage, which is also a stroke, is more common in teens. That's number one.
Right.
Number two, which is common in teens, is something called dissection. Some of these children have a habit of wiggling their neck and twisting their neck and bringing out peculiar sounds. So when they do that, sometimes they injure their artery. Of course, it can happen in an old person also. But dissection, where there is a tear in the wall of the artery, is also common in the young.
How does that happen?
Twisting your neck. In fact,
Really?
we've had patients who've been sitting in the dentist chair and have got a dissection. And dissection is like a tear. So it's a tear in the artery. So sometimes it can result in an aneurysm, or sometimes it can result in clot formation, depending on where the tear. Dissection is a completely different subject altogether, but that is one of the causes of stroke. I can give you a 1-hour lecture on dissection alone. So, and how to treat and how to diagnose and all that. But
yes,
that is one of the common causes in children.
We have extended our time, and I think we'll take a few more questions before we wind up.
So let me tell you about cost, since that was a question, and that is a question which is almost always asked. So the coils that we used, the coils which we use, I told you we use platinum coils. Those platinum coils cost anything between 25,000 and 50,000. There are various types of coils. Some are complex coils, some are simpler coils, some are coils which have a coating. So coils change, and we choose which one to use when, where. So about 25 to 50,000. The micro catheter through which we deploy the coil, that costs about 30,000. The wire with which we take the catheter up into the aneurysm costs about 20,000. The stent, the regular stent that I told you, that costs about 2 lakh rupees. The flow diverter, that is the expensive one. So there the price varies between 5 lakh to 10 lakh. And each flow diverter has its own characteristics. So this is expensive treatment, there is no question. But you have to remember that the morbidity, what we call morbidity and mortality, the chance of any complication with this is very, very low. And patients tolerate these procedures very well. And today, therefore, when patients ask me about insurance, I tell them 5 lakhs is not enough. You should basically have a 10 lakh and top it up with more. Because sometimes ICU, if a patient is on a ventilator in a good hospital, and today most hospitals are equally good, especially in the ICU, the cost is anything between 10 to 20,000 per day. And if it's a very sick patient with multi-organ involvement, like in subarachnoid hemorrhage, it can go to 50,000 a day. So cost depends basically on how sick you are. The more sick you are, ICU cost can be prohibitive. And sometimes it is antibiotics, sometimes it is stress. For instance, if it is sodium, hyponatremia, sodium goes down, we have to do it twice a day. We have to give blood, we have to give albumin. So cost is something which is there, but if they tide over the acute crisis, I have had patients who have been unconscious for 3 months. I had a pathologist who was a professor of pathology in one of the institutions. He was unconscious for 3 months. His wife was a gynecologist. She would come and ask me, "Doctor, कुछ करना है क्या? कितना खर्चा हो रहा है? करें कि नहीं करें? ये सब कह रहे हैं, मत करो. Patient is going to live like this." But you will be surprised that same doctor who was unconscious for 3 months is today practicing as a pathologist.
Wow.
So, yeah. So initial cost is high in these things. There is no question. But the long-term cost and the outcome, like he's back to earning, and of course he's back with his family, completely normal. Of course, not all patients are like that, but a large proportion of patients, if they are looked after well, and they don't have complications, they do well.
Okay.
These are bad diseases. Huh? These are bad diseases. Subarachnoid hemorrhage is a bad disease.
Well, I think in COVID times, everything is quite a challenge. Okay, here we are. You have any answer for this one?
These are better options. Physiotherapy is the only option. You have to continue with physiotherapy. There is no question.
Okay.
Yeah.
I think we will have
Any
questions.
paralysis from any cause, whether it is cervical disc disease, lumbar disc disease, whether it is whatever be the cause of weakness or paralysis, physiotherapy is the only way that one can recover. And willpower. Patients have to put in an effort themselves. Somebody else doing the effort for you is no good. You have to put in your effort yourself.
You know, there was a question from on a WhatsApp. I think it is part of, there were 4 questions together, but this one in particular, I'll read out. AIDS by chance has any effect on the CSF in brain stroke? I'm not quite sure what this exactly is. AIDS.
Yes, sir. No, I would not.
Not very clear.
It is a different disease altogether.
Yes, that is true.
In patient with AIDS, you can get stroke because the arteries can get diseased also. But CSF has nothing to do with that.
Has nothing to do. Okay, fine. Because you see, it's better that questions are raised regarding strokes than no questions, considering the lack of awareness that we have on this particular issue.
In COVID times, one of my friends had, one of my colleagues had analyzed the 100 cases that they had seen. 19 were patients who had hemorrhage, and 9 were patients who had cortical venous thrombosis. I was telling about cortical venous thrombosis. The veins getting thrombosed. So 9 of those patients, and 87 of the patients were patients who had come with a ischemic stroke, where there was loss of blood supply. So even with COVID, the most common stroke is a ischemic stroke. But hemorrhage also does occur. It's not that it does not occur.
Well, here comes a question.
Sure.
Can brain go down in generation, as in, is it hereditary?
It can be to a certain extent. That's what the slide I put up last time, if you remember. There are modifiable factors and non-modifiable factors. So there is a genetic background to it. There is. So just as it is for the heart, there is for the brain also.
That is true. Very true. But, well, I'm sure that there will be more questions as we, once we close the session, also questions will be there. Doctor, you will, because your first session also, we had some questions we had sent you. So this time, let us see. So do share your, your opinion and your answers. And I know that, Doctor, there have been personal cases which have been referred to us, and We have shared it with you, and you have been very prompt in replying. So that is not a very common thing that we have seen in the past. But thank you so very much for giving us your time and your.
I must thank you, and I must thank Sanjeev Gandhi of Hester, for having supported this, because I
Yes,
think
I know.
awareness is still lacking, and we
In
have to
fact, I
somehow
am absolutely,
generate
and
awareness.
that is something which is very much uppermost in my mind, that I will be speaking to Mr. Gandhi. If we can have some sort of an awareness campaign, you will be our guide, of course, because this is something that even families should know, because without that, it's really a bit tricky, so to speak. So about support groups, not necessarily, I know the question is related to breech candy, but are there support groups? How do people, there aren't any, is it?
Unfortunately, like I said, we can do something in the first few hours for acute ischemic stroke. And for
Mhm.
hemorrhagic stroke also we can do again in the first few hours, maybe the first few days. But when the patient is beyond that period, rehabilitation in India is a major issue. It is the family which has to do it. So
Family.
there are support groups for Parkinsonism, for epilepsy, but unfortunately for stroke, I am not aware of any such support groups. But that is a very good suggestion. Maybe somebody can take it up as an organization. Somebody can non medical non-profit organization can take it up as a support group, because these patients need rehabilitation. They need, so rehabilitation does not need only physiotherapy. It is speech therapy. It is
Yes.
occupational therapy. Patients, so that they can go and do some job, some kind of work. Otherwise, they are totally dependent. And
Yes.
rehabilitation, some patients are not able to walk, teach them how to walk. Patients are not able to write, teach them how to. So it's not only just physical exercise. It is a rehabilitation of the entire individual, which
Are
is
the
required.
hospitals in this space as well for
Uh,
rehabilitation?
Rehabilitation, actually, most hospitals today have very good physiotherapy departments and
Yes.
comprehensive rehabilitation, where everything comes together. Is there somehow, like one Reliance Hospital has got it, Kokila Benomani has got it, Jupiter Hospital in Thana has got it, and there is a very good central institute, the National Institute for Physical Medicine and Rehabilitation at Ajeri. In fact, that is a very good institute. It's a central government institute. It's at Ajeri, and
Yes,
they are
yes.
very well equipped. They have got very good what they call biofeedback and all that. So that's a very good institute for rehabilitation. But I think the problem there is one limited number of beds. They have
Hmm.
few beds, because rehabilitation is not something which can be done in 1 week or 2 weeks. It goes on for months. So if you are going to do it as an indoor patient, and many of these patients are very poor, they come from a very poor background. So they go to this National Physical Medicine Rehabilitation. They have to be admitted. Otherwise, how will you carry them from home there and then bring them back? It's not easy.
Mhm.
So once a patient goes there, is there for weeks and months. So in India, rehabilitation is a major issue.
It is.
But I would say most developing countries, but certainly for us, because here we have to spend. The government spends hardly any money on. They spend more money on preventive care. They spend much less on curative treatment,
Right.
which is their
Well, there
priority,
are.
of course, which is right also. But I
Mhm.
think now they should concentrate more on. Mr. Ranganathan has been a chief secretary, so he would be much more aware of this aspect. But I think
Yes.
we have to do something about the rehabilitation.
Well, there's much work ahead. And I think we will have to now close the session, because we have extended to about beyond time. There is so much to talk about on this subject. There are so many aspects to it. It's not just one part, there are multiple. And I think, Doctor, we will be in touch to again take up one of the things with your guidance. Let us see where we can take it and how we can be of service to the community. Um, I would also appeal to all our viewers and whoever else is going to see it later too, that do support us to carry forward this work by your generous financial support, because we do need to bring more programs. We need more awareness campaigns, and how should I say, challenging days are always ahead, and we have to make sure that we get your support financially. So do help us. Doctor, profusely thank you for your time, for the second session. You have come and you have spent so much time. You have guided us on many issues that we had asked you for guidance. We hope to have further sessions down the line, not immediately, but I'm sure there will be more questions coming up, and I will be sending those to you. So as a token of our appreciation, may we please present a virtual memento to you, and we look forward to having you with us again in the future. To all our viewers, our support partner, our young volunteers, and the Jai Hind College, all the other colleges who have joined, all the various clubs of Jai Hind College, the students, thank you so very much for being with us this evening. Thank you, viewers. Those who missed it, please pass the word around who are watching now that this will be on our YouTube channel. So do come back and see the presentation properly, because the full presentation of Doctor has not been shown today, this evening for the session. But with the report, we will have it uploaded. So please do see it, understand it, send us questions based on the presentation also. And I will forward to Dr. Karapurkar for his answers. Thank you once again, Dr. Karapurkar, Mr. Ranganathan, all my fellow trustees, and all the viewers for being with us this evening.
And Dr. Karapurkar, really extremely educative and informative session. We do look forward to having interaction with you in future also. Thank you.
Sure. Thank you very much. Thank you.
Thank you. Thank you. Good night.